Good afternoon. At the outset, let me thank Shamsad and Dr. Srijit and all the organizers for asking me to speak on this topic. I must be thankful to Vijesh for doing many of the things which I intend to sort of display. If you look at surgeries performed worldwide, you have the overall risk of complications remains very low. About less than 2% of the patients have major complications of morbidity and mortality. But if you look at the complication rates in the patients who are elderly with multiple comorbidities undergoing major surgeries, the outcomes are very poor. And in fact, the 80% of post-op death happens in these group of patients. There has been many interventions trying to improve the situations, mostly in the intraoperative period as well as the post-op period. But prehabilitation is a process which we sort of employ in the preoperative period to enhance the functional capacity of the patient before surgery, because that has been shown to improve the outcomes. And there is a growing evidence which shows that prehabilitation improves post-op pain. There is a reduction in complications, functional recovery is faster, and improved quality of life. This prehabilitation will eventually become an established part of pre-op workup in the, at least in the high-risk surgery category. So we need to understand what is going on in this field. I must make you aware that prehabilitation is different from rehabilitation. Prehabilitation is something which you prepare the patient to anticipate them for the or withstand the stress and impairments of the coming treatment, whereas rehabilitation is something which we do after the impairment has happened. This is just a slide to show what all the catabolic responses and hormone dysregulation happening during a perioperative period and surgery. Now, what are the components? How do you sort of delivering this prehabilitation as a concept? You could sort of categorize in the medical optimization, physical exercises, nutrition support, and psychological support, most of which Vijesh just mentioned. And invariably, this would take somewhere around 4 to 8 weeks to have good effect. If you look at one by one, medical, that's one we usually do. That's also addressed in the part of prehabilitation programs. We all know that stopping smoking, alcohol, and weight optimization is improve things. Management of anemia and optimizing blood sugar is the routine aspect of our pre-anesthetic workup. And whatever pharmacotherapy or the medicines patients having, you optimize them. This is also part of a prehabilitation program as such. Now the exercise, there have been a lot of articles which has proved that increasing the physical capacity of the patient improves the outcome, even though outside the prehabilitation program. So this is also included in the prehabilitation programs. You assess the baseline capacity of the patient either by doing a 6-minute walk test or a Duke's score index or CPET. Then you specify exercise regimens and reassess them before surgery so that to assess whether the functional capacity has improved. And what is the optimal regime? There is no such optimal. It's not yet. There is no optimal regime prescribed, but it basically consists of a combination of strength exercise and aerobic exercises, roughly around 3 to 5 sessions per week, lasting for 30 to 60 minutes. Now, where do you do the exercise? You can do it either hospital-based or home-based. But the problem with home-based is because the complaints may be less, but it's convenient for the patient and less of expensive. But what has been shown, the hospital-based programs demonstrably has demonstrated that the functional capacity improvement is much better with hospital-based exercise programs. There are many guidelines and recommendations on preoperative exercise. This is actually outside the prehabilitation program because this has a one model of enhancing capacity has been advised long back, but some of the guidelines, there are some guidelines regarding what type of exercise and what regime is. Nutrition, again, we all know that poor nutrition status means poor outcome. So preoperative nutrition status, major surgery, pre-op starvation, all contribute this poor outcomes. So what do you do when you see a patient? You had formally screen the patient for the nutrition status of patients. Ideally, 7 to 10 days of enteral nutrition is prescribed, and it will benefit both the malnourished groups as well as the well-nourished patients coming for surgery. This include at least 1.5 gram per kg of proteins daily, which is actually more than the usual recommended, just to limit the nitrile loss. 1 word about pre-op carb loading, which is actually already in the RAS protocol, which actually promotes the anabolic state, again minimizing loss of protein, lean body mass, and muscle function, improving the outcomes, has shown to improve the outcomes. There's some evidence about immunonutrition, again with using omega-3 fatty acids, which are also shown to improve the outcomes, especially in wound infections and post-operative recovery. Another important aspect of the prehabilitation program is the psychological support. We all know that patients advised surgery do have fear and anxiety, and psychological stressors actually produce same sort of hormonal imbalance which surgery or catabolic response surgery produces. So the aim of psychological support is primarily to reduce the distress and anxiety, and secondly, to motivate and empower the patients to comply to the prehab regimes of exercise and nutrition. And this includes a combinations of cognitive interventions, relaxation techniques, and procedural informations. This is one clinical pathway from Canadian McGill University Hospital. They are sort of the pioneers in trials in prehabilitation programs. You basically assess the patient, screen the patient for the exercise functional capacity, the nutrient status, and their anxiety or depression score by the use of HADS or hospital anxiety depression scores. Then you assess their capacity and their nutrition levels and their depression answer. Then you intervene with your exercises, nutritional interventions, and psychological support, and then reassess, then make them fit for surgery. That is one thing. There's another model of prehabilitation program. Exercise and physical activity. You attain some goals regarding the prehabilitation, then decide upon whether the patient is ready for surgery. Again, one protocol of exercise, nutrition, mental support, and stopping smoking and cessation programs. Now, what is the physiological basis why we advise these prehab programs? We all know that cardiorespiratory fitness is a strong predictor of all-cause mortality. In fact, it's a much more powerful predictor than our traditional factors like hypertension, diabetes, or obesity. And surgical stress is a catabolic response state, and this depends on the type of injury and the patient response. What by prehabilitation is meant to improve the patient response, that the catabolic response is minimized. And naturally, this prolongs recovery from surgery. So by enhancing the functional capacity, the prehabilitation patients retain higher levels of functional ability and recovers rapidly to a minimal level of functional independence. From the pictorial description of the prehabilitation concept, if you look at the line A is usually a normal patient who undergoes surgery. They recover quite okay. But if a poor reserve patient, that's line B, is undergoing surgery, you can see that they hardly recover to the normal or not even close to the normal level. So they're still in a functionally dependent area. Whereas a prehabilitated patient, which is line C, if you prehabilitate a patient and they undergo a surgery, and you can see how fast they recover and comes to a normal disease. Even in such patients, if there are some complications happens, like in a day, even then they recover quite fast following prehabilitation. Again, a pictorial description of how prehabilitated with the green line patients, how fast and quicker they recover following prehabilitation compared to patients who had no prehab. So having said, what the literature says? There are quite exhaustive list of literature on this topic. This is a narrative review from again from the Canadian people. whether combining prehabilitation and enhanced recovery improves is better, or do we need it separately? So they found that prehab actually complements ERA's protocol to improve the outcome. And the suggestion is a surgical recovery actually starts before the incision is made. And prehabilitation has shown to improve the augments reserve and enhance the capacity of the patient. This is one of the trial. Perhaps will give us a more insight into the how prehab is going to affect the outcome better, because all the trials, presently available trials, are of smaller numbers and heterogeneous. This is basically a multi-center trial. One group with prehabilitation, other group without prehabilitation, and the standard perioperative ERAS protocol care will be given for intraoperatively. And what they are looking at is there any improvement in functional capacity before surgery and post-surgery 6 weeks. And as a secondary outcome, they look at the comprehensive complication index, the health-related quality of life, and length of hospital stay. Of course, they are looking at the financial aspect also as well. And they did a pilot study before the recruitment process, and what they found was that in prehabilitated patients, the percentage of improvement in the functional capacity as assessed by cis-menital walk test is hugely different from the patient who had no prehabilitation. That's a darker line. Another of the review articles again showed that prehabilitation leads to reduction in complications. They have faster recovery after surgery. So there is a mounting evidence that prehabilitation improves outcome. But the problem is it is challenged by the methodology of the trials available as of now, because most of the trials were of smaller numbers, and the outcomes checked were of different outcomes were actually looked after, and there was a heterogeneous group of patients. Actually, not one size fits all, as Vijesh said in his previous talk. We need to identify which group benefits and select appropriate interventions, whether we need to use a unimodal approach or a multimodal prehabilitation. All these things has to be answered. And now, what is the structure? Where does the structure of this prehab clinic happens? Obviously, it has to happen in the preoperative clinic, and it should comprise of a team of multidisciplinary of anesthetists, surgeons, internists, nutritionists, physiotherapists, nurses, psychologists, etc. And it has to come to a stage that it will come to a stage where the once the surgery is advised, patients are referred to this clinic, and this clinic assesses them comprehensively by objective assessment and structured individual rehabilitation, and then decide whether the patient requires can withstand surgery, or it may happen in that direction. The other flip side with the problem with the prehabilitation programs is the time. Ideally, or most of the literature says that it should be anywhere between 4 and 8 weeks. So can we ask the patient, or is it possible for the patients to wait 4 to 8 weeks once they can diagnose, especially in cancer surgeries and all? That is a difficult question to answer. So that has also been looked right before implementing the programs. So just to summarize, prehabilitation, we know that there is evidence that multimodal prehabilitation leads to reduction in complications and faster recovery. Although it has been adopted in many guidelines in many places, we are still at the threshold of implementation because lack of concrete evidence. That's what from the literature. So the question is, should we offer the patients to get fit now, or do we need more evidence before implementing the program as a standard protocol in our our surgical practice, especially in high-risk patients or old patients? Thank you.